Imagine surviving cancer.
Yeah.
You make it through the surgeries, you endure the grueling rounds of chemo, and you finally get to that moment where you ring the bell in the clinic. You're thinking, okay, the absolute hardest part is over.
Right, the victory lap.
Exactly, the victory lap. But then you start the long-term maintenance medication to keep the cancer away, and suddenly you are waking up completely drenched in sweat like 5 times a night.
Yeah.
And during the day, the sudden, just suffocating heat takes over your body. It happens during meetings, at the grocery store while driving, and it just happens over and over again, completely out of your control.
Exhausting.
It is. You beat the odds only to find yourself willingly contemplating quitting the very medication that is keeping you alive, all because you just can't stop sweating.
And that is a devastating reality for, a massive number of patients. And it operates almost entirely in the shadows. Like you said, we view survivorship as this triumph, but for many, it initiates a severe physiological crisis.
Yeah.
Up to 90% of premenopausal women undergoing chemo and anti-estrogen therapy experience severe, debilitating hot flashes and night sweats.
Wait, 90%? That's almost everyone.
Almost everyone. And it's not just women. Men undergoing androgen deprivation therapy for prostate cancer, they are hit with the exact same debilitating symptoms.
And people are just tapping out, right? Because looking at the clinical data we pull for this, somewhere between 25% and 55% of patients simply quit their life-saving endocrine therapies.
Yeah. Drugs like tamoxifen or aromatase inhibitors.
Right. They quit because the side effects become unbearable. They are literally abandoning treatments that prevent their cancer from returning just to escape the hot flashes.
Which is exactly why our mission today is so critical. For this deep dive, we are taking a really comprehensive look at a stack of clinical trials, the latest ASCO guidelines, that's the American Society of Clinical Oncology and Oncology journals. We want to answer one specific question.
What non-hormonal options actually exist for managing severe hot flushes in cancer survivors?
Exactly, because the dilemma here is incredibly frustrating. The historical gold standard for treating hot flashes has always been estrogen.
Right.
But for hormone-driven cancers, like many breast and prostate cancers, adding hormones back into the body is, well, it's like feeding fertilizer to a weed you just spent a year trying to pull up.
Oh, man. Yeah, you simply cannot do it without risking a major recurrence of the disease.
You can't. So we have to find alternative, non-hormonal solutions. And to really understand how to do that, we first have to understand the actual biology of the burn, like what is physically happening in the body to create this sensation of extreme heat.
Right, because it feels so real to the person experiencing it.
It is real. The current research points to a sudden drop or a massive fluctuation in sex hormones. When those hormones plummet due to cancer treatments, it triggers a spike in a brain neurotransmitter called norepinephrine.
Okay.
And that chemical spike does something very specific.
Yeah.
It dramatically narrows the body's thermoneutral zone.
Okay, I want to unpack this thermoneutral zone idea. Because reading through the sources, it completely changed how I view this entire phenomenon.
Yeah, it's fascinating.
Think of your body's temperature regulation like the thermostat in your house. Usually you have a comfortable range. If the house is set to 70 degrees, it might drop to 68 or rise to 72 before the heating or cooling actually kicks in.
Right, you have a natural margin of error.
Exactly. But when you wipe out estrogen or testosterone, that margin of error shrinks to virtually zero.
The parameters just become incredibly rigid. So if your core temperature shifts even a tiny fraction of a degree from, say, drinking a warm cup of coffee or feeling a momentary spike of stress or just shifting under a heavy blanket at night, the furnace blasts on.
The brain literally panics.
It does. It perceives that tiny fluctuation as a dangerous overheating event, and it triggers this massive autonomic response to dump heat as fast as possible. The blood vessels in your skin dilate, you flush red, your sweat glands just go into overdrive, and your heart starts racing.
So it's a false alarm of the highest order. The body is reacting to a fire that just doesn't exist.
Precisely.
And what really struck me while looking at the notes is how identical this mechanism is across the board. Because here is where it gets really interesting. This isn't just a women's health issue.
No, not at all.
Men who are on androgen deprivation therapy or ADT or who are post-orchiectomy for prostate cancer, they suffer the exact same physiological attacks. The sudden heat, the flushing, the heart palpitations, the profound anxiety that often comes right before the physical wave.
Yeah, and for men on those specific therapies, this is rarely just some temporary adjustment period. The data actually shows a substantial proportion of men are still highly symptomatic 5 to 8 years after starting ADT.
8 years? Wow.
Yeah, Try to visualize living with unpredictable attacks of sudden heat and sleep disruption multiple times a day and night for 8 years straight. Though the compound exhaustion and the distress, I mean, they are enormous.
Okay, so if the thermostat is fundamentally broken and we are not allowed to use hormones to fix the hardware, what do we actually do? We have to look inside a very weird repurposed medicine cabinet.
We do.
Because I'm looking at this list of first-line non-hormonal treatments, and the most prominent tools seem to be antidepressants. Like, wait, if a patient's core issue is temperature regulation, why are we giving cancer survivors antidepressants or anti-seizure meds like gabapentin?
It does seem like a total mismatch on the surface.
Yeah.
But it all goes back to that underlying mechanism. When oncologists prescribe SSRIs or SNRIs, so drugs like venlafaxine, which is Effexor, or paroxetine, which is Paxil, they aren't using them to treat depression in this context.
Right.
They are targeting the nervous system.
Right.
These medications alter the levels of specific neurotransmitters in the brain, including that norepinephrine we mentioned earlier. By chemically stabilizing those signals, they essentially force that narrow thermoneutral zone to widen back out.
So you aren't treating the sweat glands directly. You are just tricking the brain into ignoring the false alarms.
Exactly. You are dampening the hyperactive communication in the brain. And the clinical efficacy is actually really substantial. One trial looked at venlafaxine and found it reduced hot flashes by nearly 8 episodes a day.
Wow.
Yeah. And when they measured it against a blood pressure medication called clonidine, which is often used for the same purpose, the blood pressure drug only reduced them by 5. The antidepressant was the clear winner.
But the strategy of borrowing drugs from other medical disciplines, it brings up a huge issue, which is tolerability.
Absolutely. Side effects are a huge factor.
Right. There's this fascinating Pepsi Challenge-style trial in the stack. Researchers took women experiencing at least 14 severe hot flashes a week and had them try the antidepressant venlafaxine for 4 weeks.
Right.
And then they had them switch to an anti-seizure medication called gabapentin for another 4 weeks.
Which is great because those crossover trials are highly valuable. The patient gets to be their own control group so they can compare the two interventions directly.
And the results were wild. Both of these repurposed drugs were highly effective. They both reduced the hot flashes by 66%.
A tie, essentially.
Yeah, a tie on efficacy. But at the end of the trial, when researchers asked the women which one they actually preferred to stay on, 68% chose the antidepressant. It entirely came down to the side effect profile.
Because the gabapentin caused more issues, right?
Exactly. The anti-seizure medication caused significant dizziness and increased appetite, while the antidepressant really only caused some mild nausea, but overall it had fewer negative daily disruptions.
And that trial perfectly illustrates the reality of survivorship care. Efficacy is only half the battle, because if a drug cures the hot flashes but makes you too dizzy to safely drive a car, it simply isn't a viable long-term solution.
No, of course not.
But there's a much more severe warning embedded in the oncology guidelines regarding these repurposed medications, particularly concerning breast cancer patients on tamoxifen.
All right, this is something every listener needs to be incredibly aware of. Treating the symptom in a vacuum can be dangerous. We have to talk about paroxetine or Paxil.
Yes, paroxetine is a very potent antidepressant, and it's highly effective at minimizing hot flashes. However, it is strongly, emphatically not recommended for women taking tamoxifen.
And why is that?
To understand why, you have to look at how tamoxifen actually works. It is what we call a prodrug. So when you swallow a tamoxifen pill, the chemical in that pill isn't what fights the cancer. It first has to travel to your liver, where a very specific enzyme breaks it down and converts it into the active compound that actually protects your body.
And paroxetine essentially builds a brick wall in front of that liver enzyme.
It does. It is a potent inhibitor of that specific metabolic pathway. If you take the two drugs together, the antidepressant blocks the liver from doing its job, which means the tamoxifen is never converted into its active form.
Oh, wow.
So you might find relief from your hot flashes, but you are drastically lowering the effectiveness of your cancer-fighting medication.
Which completely defeats the purpose of taking the maintenance therapy to begin with. It's such a stark reminder of how carefully these interventions need to be managed by an oncologist.
Absolutely.
But researchers kept digging into the pharmacy of repurposed drugs, and they found a pretty wild curveball in the Alliance trial, a drug called oxybutynin.
Yes, oxybutynin is traditionally used for a completely different issue. It's designed for overactive bladder and urinary incontinence.
Right. And yet they gave breast cancer survivors twice daily doses of this bladder drug, and within 6 weeks, it massively improved their hot flash symptoms compared to a placebo. The women reported significantly better sleep and a huge boost in their quality of life. But and I have to ask the obvious question here. If oxybutynin is designed to dry out an overactive bladder, isn't it going to dry out everything else?
Well, that is the main caveat. Oxybutynin is an anticholinergic medication, meaning it blocks the action of a neurotransmitter called acetylcholine. Now, acetylcholine is heavily involved in the body's sweating response. So by blocking it, you shut down the sweat.
Okay, that makes sense.
But you also impact other systems. About 9% of patients taking it develop moderate to severe dry mouth. However, why this really matters is that oxybutynin bypasses the liver enzyme issue entirely. It doesn't interfere with tamoxifen.
That's huge.
It is. So for someone experiencing 20 severe hot flashes a day, a little dry mouth is a highly acceptable trade-off for a safe, non-hormonal treatment.
Right, so repurposed pills are clearly doing a lot of heavy lifting. But they all come with side effects, whether it's nausea, dizziness, or dry mouth. What happens when a patient wants a completely natural approach? Because honestly, I assume the data on non-pharmacological therapies would be a bit flimsy, but it is surprisingly robust.
It really is.
Yeah.
There is often this assumption that behavioral or natural interventions are merely complementary, like maybe they offer a placebo effect but lack real clinical power. The data tells a very different story.
Let's talk about acupuncture. There was a 50-woman study published that put ancient Chinese medicine head-to-head against modern pharmaceuticals. Half the women received acupuncture, and the other half took the antidepressant venlafaxine, or Effexor.
And the clinical outcomes are fascinating. Both interventions worked equally well at reducing the frequency and severity of the hot flashes.
Wait, really? Equally well?
Equally well. But the divergence in the side effect profile is what makes this so noteworthy. The acupuncture group experienced 0 negative side effects. None. While the pharmaceutical group had to navigate the nausea and dizziness we discussed earlier.
That's incredible, but the follow-up data is the coolest part to me. 2 weeks after the treatment stopped, the women who had been taking the antidepressant saw their hot flashes surge right back up. The drug left their system, and the broken thermostat took over again.
Right.
But the women in the acupuncture group, they kept their cool. They maintained their symptom relief long after the needles were gone.
Which suggests that acupuncture may not just be actively suppressing a symptom while a chemical is present in the bloodstream. It might actually be modulating the nervous system in a more enduring way, helping the body recalibrate its own internal thermometer. And we see similar, profound physiological changes resulting from cognitive and behavioral approaches.
Yeah, I have to admit, I was highly skeptical when I saw clinical hypnosis listed as a recommended treatment. It sounds like a parlor trick, right? Not oncology care.
A lot of people feel that way.
But there was a trial involving 60 breast cancer survivors who utilized clinical hypnosis, and the results were undeniable. They achieved a 62% reduction in their overall hot flash score.
And that score measures both frequency multiplied by severity.
Exactly. The control group saw almost 0 improvement. A 62% reduction from just changing thought patterns is massive.
It is. And the major oncology guidelines strongly recommend cognitive behavioral therapy, or CBT, for the exact same reason. The ManCanon-2 trial, which focused on men undergoing prostate cancer treatment, evaluated a structured CBT program. Over the course of 6 weeks, it significantly helped them manage the distress, anxiety, and depression that were compounding their physical symptoms.
Though the effect did fade a bit by 6 months, right?
It did, but it proves how intertwined our mental state is with our physical symptoms.
But how does talking to a therapist or undergoing hypnosis actually stop a physical sweat response? It feels like we are mixing up psychology and physiology here.
Well, they are inextricably linked, especially through the sympathetic nervous system. That is the system responsible for your fight or flight response. You know that sudden cold sweat, heart-pounding sensation you get when you are startled?
Oh, yeah, sure.
Baseline anxiety keeps that system slightly elevated at all times. And research shows that high baseline anxiety confers a 3-fold increased risk of vasomotor symptoms like hot flashes.
Oh, I see. So if you are constantly anxious about when the next hot flash is going to hit, your body is essentially hovering right on the edge of the trigger point.
Precisely. By using CBT or hypnosis to lower your baseline sympathetic arousal, you are physically widening that thermoneutral zone. You're giving the body a larger buffer before the false alarm trips.
That makes the connection so much clearer. Now, speaking of altering the nervous system, we need to introduce the most sci-fi sounding treatment in the stack, the stellate ganglion block, or SGB.
Ah, yes. This represents a really fascinating pivot, taking a technique traditionally used in pain management and applying it to endocrinology.
I read the description of this procedure several times to make sure I wasn't misunderstanding it. So what does this all mean? We are injecting anesthetics into a nerve bundle in the neck to stop sweating.
It sounds extreme, but it goes back to that sympathetic nervous system we were just discussing. The stellate ganglion is a collection of nerves located in the neck. Think of it as a major junction box for the sympathetic nervous system, routing signals that control the fight-or-flight response and body temperature regulation.
Okay.
The theory behind the procedure is that this junction box is stuck in an overactive loop due to the lack of hormones. By injecting an anesthetic directly into that nerve cluster, you temporarily block the transmission of those signals.
So it's like pulling the plug on a malfunctioning internet router, waiting 30 seconds, and plugging it back in to force a hard reset.
That is a very apt way to visualize it. You are forcing the autonomic nervous system to reboot, and the clinical outcomes for patients in acute distress are notable.
There is an SGB pilot study of 34 women with severe treatment-resistant symptoms. Like, nothing else worked. They received the nerve block injection. By the end of the first week, their hot flashes plummeted by 64%.
That's a huge drop.
And their sleep quality improved massively. But there is a catch regarding durability, isn't there?
There is. The longevity of the reset varies. By week 24 of that study, the reduction in hot flashes had faded from 64% down to about 47%. So it's an incredible short-term reset for breaking a cycle of acute distress, but maybe not a permanent one-and-done cure for everyone.
Still, for someone completely out of options, cutting the severity of their symptoms in half for 6 months from a single injection is a massive victory.
Oh, absolutely.
Up until now, though, every single thing we have discussed, the repurposed antidepressants, the bladder pills, the acupuncture, the neck injections, they are all indirect. We are hacking secondary systems to calm down the broken thermostat. But the future of survivorship care is shifting because science is finally targeting the absolute root cause of the problem.
Yes. To appreciate this leap forward, we have to look directly at the hypothalamus, the actual physical location of that internal thermostat. Inside the hypothalamus is a specific cluster of specialized cells that scientists refer to as KNDI neurons. For our purposes, you can think of them as the brain's central fire alarm system.
And how do these specific neurons interact with estrogen?
Estrogen acts as a protective glass case over the fire alarm. It binds to neurokinin, or NK receptors on these neurons, keeping them calm and stable. But when you completely remove estrogen from the body, whether through natural menopause or through anti-estrogen cancer therapies, you remove that protective glass. The declining estrogen disrupts the balance of the NK3 receptors.
So the neurons become highly reactive.
Exactly. They enlarge, they become hypersensitive, and they start tricking the brain into thinking the body is dangerously overheating.
So rather than trying to cool the body down after the alarm is already ringing, scientists simply built a drug to block the specific receptor on those fire alarm neurons, a drug called fezolitant, or Veozah.
Right.
The FDA recently approved this drug for menopause, and it's like a switch. Within a day or two, the flushes just go away. But wait, if it works so perfectly at the source, why aren't cancer patients immediately being prescribed this?
Well, it comes down to the exceptionally rigorous safety standards within oncology. Major oncology guidelines, like ASCO or ESMO, do not currently include Veozah for breast cancer patients. It is currently off-label because we are still waiting on phase 3 clinical trials, like the Highlight 1 study.
Oh, so they need to prove it's safe alongside the cancer meds.
Precisely. Just like we saw with the antidepressant paroxetine blocking the liver enzyme, oncologists need definitive data proving that this new compound doesn't interact negatively with vital anti-estrogen cancer therapies.
That makes total sense. You can't just assume a drug is safe until you prove it. But there is a second-generation compound in the pipeline that is generating intense optimism. The newest drug on the block, elinzanetant, or Lincoet.
Yes, and it targets those exact same fire alarm neurons, actually blocking both NK1 and NK3 receptors.
And the crucial difference is how it's being studied, right?
Exactly.
Yeah.
Unlike Veoza, alinzanetant has actually been studied in women with breast cancer. The OASIS-4 trial was specifically designed for women who are actively taking tamoxifen or aromatase inhibitors, and it shows massive promise for reducing the hot flashes in that specific vulnerable population. This is the absolute cutting edge of survivorship care.
It's amazing. We are moving away from borrowing pills from the psychiatric or urology departments and toward therapies built from the ground up to fix the exact neurobiology of a hot flash.
It represents a total paradigm shift.
Let's bring all of this together. If you are listening to this and you or someone you love is battling cancer, the most critical takeaway is this. Severe hot flashes do not have to be a permanent, miserable life sentence. And they definitely shouldn't be the reason someone stops taking their cancer meds.
Absolutely not. The arsenal of non-hormonal tools is massive now. From repurposed bladder pills and antidepressants to ancient acupuncture to cutting-edge NK3 blockers.
You just have to advocate for yourself. But before we wrap up, I want to leave you with one final kind of provocative thought to ponder. As we were looking at all these diverse treatments, something profound stood out about the mind-body connection.
Yeah, it's perhaps the most philosophically intriguing aspect of the entire condition. We know definitively that a hot flash is triggered by a purely physical, chemical event, a plummeting hormone level that initiates a violent physical reaction.
Right, a biological cascade. And yet, simply undergoing cognitive behavioral therapy or focusing the mind through hypnosis can effectively reach into the autonomic nervous system and turn that physical temperature back down.
It's wild to think about.
It really is. Think about what that reveals. If a physical drop in estrogen can trigger a phantom heat wave in your body, but simple cognitive behavioral therapy or hypnosis can effectively turn the temperature back down, what does that reveal about the profound, deeply intertwined connection between our conscious mind and our autonomous bodily functions? The mind isn't just a helpless passenger reacting to the body's chemistry.
No, it's actively holding one of the wrenches. True symptom management requires treating the entire organism.
It does. We started this deep dive looking at a hidden crisis, but as we've explored, science is finally mapping this invisible landscape, offering a multitude of ways to recalibrate the system. Thank you for joining us on this deep dive. Keep questioning, keep learning, and please discuss any of these options with your own oncology team. See you next time.